Good morning, everybody. First of all, thank you for allowing me to participate, but I specifically want to thank Dr. Edison and Dr. Yulita for actually setting up my presentation perfectly. The first question I have, is it okay if I speak in English, or should we have Dr. Muska translate? I heard that everybody is unfortunately much more familiar with English than I'm with Bahasa, so my apologies. The reason I appreciate my previous speakers, they give excellent presentations from a perspective of public health and from the government's perspective. This allows me to actually present a little bit what I would call where the rubber meets the road. I am still a practicing physician, as you have heard, and I'm actually very proud of that, but I am also involved in Mayo's administration, and sometimes it is a bit frustrating to combine the two, because regulations are wonderful, they are needed, they are necessary, but when they come without a cookbook on how to really do it and implement it, that's when things get really tricky. And so let's try to kind of walk through what I'd like to talk to you about. First of all, I'm going to continue where Dr. Edison left off. There are significant challenges in the coming era, and just like in Indonesia, America is going through the most profound changes in how we treat patients. At this point, we actually don't really fully understand what these changes will bring for us, how we're going to practice in the future. But I can promise you one thing. We're going to practice differently. I'm not saying that's good, I'm not saying it's bad, but we have to get ready for the change. If we are unprepared, we're going to be running behind. So what are the challenges or the tasks? First of all, the world has become connected. We are now facing an ever-increasing transparency. America is probably a little bit further ahead than Indonesia. Data on outcomes are available on every website. Data on successes of hospital available on every website. The questions we are getting from patients, especially when it is an invasive procedure, is how well are you at your hospital doing? This will come, and we need to be prepared for that. The next thing, the number of rules and regulations are increasing. We can complain about that, but it's actually necessary because the world is getting more complex. Medicine has changed drastically. Resources are becoming scarce. Actually, Indonesia is in the admirable position that they are beginning to increase their spending. Currently, Indonesia is spending about 1 to 2% of their GDP on healthcare, and they're going to adjust it, as far as I can understand from a meeting with the Minister of Health, to roughly 12% to be in line with the European countries. America is currently spending 18% of its GDP on healthcare, and if left unchecked, this number would surely rise. Last but not least, every physician, and this is where I really feel the pain, live it every day, every physician is complaining about the non-practice duties that are rising, that are taking away from involvement. And that is something that is concerning, because on one hand, we are allowing physicians to undergo a very specialized education, only then to have them fill out forms. That's just not right, because you want to leverage this education to the best possible form. They should be doing anything but filling out forms. So there is no action without a reaction, and to bring this across the last point, I call it the dilution of quality, and people really do not fess up to this. If you have a system where you have a certain amount of people and a certain amount of tasks, if you now increase the tasks with the same number of resources, you are going to get a dilution in quality which continues over and over until people start to complain because the quality is no longer there. So in other words, I have one rule. If you have a regulation that you are writing down, you need to come with a solution how this is implemented with the resources. And this is actually part that is a theme that's recurring over and over again in my talk. I thought, coming from the Mayo Clinic, I should actually start into my talk with a statement that is as true now as it was then. No one is big enough to be independent of others. When you think this statement through, you have arrived at what's called integrated care. And integration is of absolute importance. Why? Everybody in America knows this painting. It's General Washington crossing the Delaware as the first step towards independence of the US. Every school kid knows this painting. Do you know what would happen if there wouldn't be teamwork of people who are actually helping in the winter to cross this river? Washington would look like this. Do you know where his boat is going to go? Pretty much down the river. You know, we take this for granted. We are using the word teamwork over and over and over again, but we're not filling it with life. And that's very, very critical. The second statement from the son of Mayo is, if we are satisfied, we're lost. What does that mean? It means that all the time we need to check and recheck our practices, our outcomes, to see if we are still up to date, if we can improve, or if we can change something for the better. This whole exercise is actually very, very simple if you take the mission statement, and I actually believe that the success of Mayo Clinic comes from somebody getting this right. There is we have as our mission statement one single sentence, and that sentence is, the needs of the patient come first. When you analyze through the eyes of the patient, things actually fall into place. Things are easier than you think. However, this is how things have changed. These are the good old days. The gentleman with the horse carriage who would come to your house and would help you with sick children when you were sick. A wonderful personal relationship. Or if you want to look at it this, I call her Dr. Matilda. Dr. Matilda had her bag of knowledge, this part, and she would have a very personal relationship with you. She would come to your home and she was easily accessible. What's the problem with this? The disadvantage is that she was, or he was, a single source of expertise. He or she worked in isolation, and even with her best intention, it would be unable to have coverage 24 hours, 7 days of the week. What do we have today? This is what we have today. We have specialization to the absolute degree with an unbelievable armamentarium of diagnostics. So we have evolved tremendously. As a result, we have many more resources at our fingertips than ever before. We have teams that are working together for the benefit of the patient, and because of that, we have round-the-clock coverage. However, we also lost something. We lost the personal touch, and if there's one thing in this ever-complex system, the patients find it often very inconvenient to interact, because who should I go to? Who is my best first contact? How do I get into the system? Things we often don't really address. And because we are often in these hyper-specialized places, we actually make ourselves involuntarily inaccessible, because we are not a good match for every situation for the patient. This is just not to drive this home, but this is the mission statement of the Mayo Clinic from previously the vision statement. And I would like to point out that both in the mission as well as in the core business statement, the word integrated plays a key role for us at Mayo Clinic. So let's spend a moment on what does that really mean from a patient perspective, because that's really what counts. From a patient perspective, it means easy access to healthcare. It means that you provide unhurried examinations, which are comprehensive, but they are also focused on the patient's leading symptoms. You perform supportive testing that helps you in further decision making. You integrate seamlessly for the patient from the doorman to the discharge. If you go through hospital processes, there are so many steps where patients will say, I had to wait here, I had to wait there, that person was not available. Those are serious problems for the patient that make it less successful. And last but not least, something that I think is somewhat lacking in Indonesia is the continuous support after the acute health care episode is over. When you have saved the patient from a heart attack, when you have him recovered from a stroke, the subsequent support to prevent further recurrence of such events is critical in a better, more efficient healthcare system. So in a very simple graphic form, you have the access, you have the evaluation, you have the supporting laboratory tests, the supporting diagnostic tests, then the patient undergoes the intervention, but then it's continuous care. Something similar than Dr. Edison pointed out, but a little bit more detailed in terms from the patient's perspective. Now let's turn this around. What's the provider looking at? What is necessary from a provider perspective? You have to have collegial, cooperative staff teamwork with true multi-specialty integration. I am not saying, as you will see later in my talk, that that has to be all under one roof. You will actually find that with modern technology, we are in the unbelievably advantageous situation where we can actually focus our resources, not in one spot, but we can distribute them so that they are more equally available and we don't have to bunch everything in one location. You have to have the unhurried examination. If you cannot listen to the patient and you don't have the time, I can tell you this will be a patient who is not optimally and successfully treated. Physicians need to take personal responsibility for directing patient care over time in collaboration with the personal physician. A concept that sounds so simple, but is actually in reality for many not achievable. You have to provide the highest quality care with compassion and trust. You have to have respect for the patient, the family, their beliefs, how they approach the system, and the patient's local physician, because he should be the one who is taking over after the acute care episode is over. You should make sure that you evaluate in a timely and efficient manner, not having the patient, successively going through several weeks of assessment, especially if there's potentially a life-threatening situation. And you have to have access in your care, not necessarily that you have it all yourself, to the most advanced, innovative diagnostic, therapeutic technology and techniques. This is where things can get very complicated when a government begins to control resources, when authorization forms need to be filled out. I would actually suggest that a better hybrid would be evidence-based best practices, and I'm going to talk a little bit about that, and measure against that. But I would put part of the responsibility back on the shoulders of the hospital. Not that they should be let get away with everything, but if they are accountable, they need to have some freedom of maneuvering. Otherwise, you are literally practicing from afar from a government chair, and that never worked. Germany went through this in the 50s and 60s until they changed the system back to give control to the hospitals with appropriate supervision. That's a different thing. Now, what's the environment that is needed for such an integrated care? You have to have at every level the highest quality staff that's mentored in the culture of the institution and is valued for their contribution, something that is not always easy. You have to have the valued professional allied health staff with the work ethic, the expertise, and they need to be devoted to the mission and vision of the institution. You have to foster a scholarly environment where curiosity is being promoted. You have to have physician leadership. I know that that's a concept that is for many of you kind of nondescript, but I worked at several institutions in Europe before I came to Mayo Clinic, where every committee is essentially, every critical committee is led by a physician. This does not mean that they're making all the decisions, but they're giving the input to provide the critical proximity to the patient care. I have seen too many electronic medical records being built by, forgive me, techno geeks that had no clue how practice is really done. And then they are sold to an institution, and essentially the statement is, here's your EMR, go make it work. That's wrong. It has to be the other way around. You will hear tomorrow from the talk from Julia, who is an expert in electronic medical records, how actually critical the contribution of everybody who cares for the patient, not just physicians, is for this process. You have to have an integrated medical record. Why? Because of the ever-increasing complexity of information, and it needs to be readily and always available. This is an important point. You have to have professional compensation that creates an environment in which you can work in the way we just described. And at Mayo, we also emphasize the unique professional dress, decorum, and that the facilities are of the highest standard. This is a little bit how we are approaching this. The quality, the individualized medicine, the science of healthcare and its delivery, and integrating it all. So when you take a look at it, you have to have the quality, which actually translates into value. And what is value? Value is the outcome divided by the cost to achieve this outcome. You can have the best outcome where you bankrupt the national resources, and you can have a bad outcome that's still equally expensive. So value is actually something that incorporates outcome, safety, and the cost. It has to be trusted, it has to be affordable. You have to integrate it. We at Mayo strongly believe this. We actually select all of our staff and their compatibility to integration. And then the knowledge and the delivery need to be combined. This is actually the core business that every hospital should perform, or every healthcare institution. And there should be actually a marker, a demarcation line between here and the surrounding necessary regulations. If you are invading the delivery of the core business by regulations, you are actually stymieing and sometimes paralyzing the optimal healthcare delivery. I'm going to now go into a couple, for the remaining of my talk, into a couple of opportunities that were not available, that are coming on the horizon, and that I think we should take full advantage of in healthcare delivery. Briefly, those of you who are familiar with the new concept of open data. Open data, if I would have used this term 10 years ago, I think I would have been thrown out of any meeting that was any self-regarding. Why? Because data had to be protected. Data had to be kept secret. Data were not shared. That's wrong. I am not saying I'm sharing my personal data, that I'm overweight, that I may have a little bit of blood pressure, and what I'm doing in the evening, and what are my foods. That's not what I mean by open data. What we have learned, that you can take even personal information and you de-identify this. Why are open data, however, so critical? Because there is actually an estimate, and I'd like to ask the audience, of how efficient do you think we are in analyzing the amount of data that we are putting into these databases? How much do you think we are getting out? 1%? 5%? 50%? Or are we really analyzing them well? Who thinks 1%? Nobody. God, you have optimists in this room. Who thinks 5%? 10%? 50%? God. We have optimists. They're all thinking 100%. There is currently consensus that the effort and the amount of data we're putting into databases, healthcare databases currently, are evaluated to the tune between 2 and 3%. This is how bad we are. There is so much data out there that we are not tackling that it's actually frightening, because there is my analysis as a practitioner. Let's not do that. Let's just kind of meddle on, because we are saying we are collecting all the data. We are doing nothing with it. The open data concept is different, because it allows anybody who wants to think about the data to grab a data set and analyze that. It needs to be, I don't know how you're all younger than I am, but I remember that data sets were not compatible. They were not transferable. You were going from IBM to a Dell, forget your data set. It wasn't compatible. This is closed data. The cost, actually in an open data concept, you put these data out. They are de-identified. You cannot tag them to a person, but you can analyze trends. You can actually get unbelievable amounts of information. There is an open data, you have unlimited rights to reuse and redistribute data. Something, a concept that previously was completely unavailable. This is a little bit on where the open data are placed. They are not encompassing all data. They are including some of personal data de-identified. President Obama actually made it a point that the very first thing he signed into law was the open data concept. He felt it's so important that with the amount of data that the United States government had amassed and the tiny fraction that was actually used, that this was such a waste of resources that he felt that this needed to be opened up. And indeed, research by McKinsey has shown that actually the savings in an open data system is enormous. We are believing that right now in the US, in healthcare alone, $300 to $450 million are saved annually by allowing data to be accessed and analyzed. Overall, the savings is much higher. You can see it in every other industry that this concept is already used. Why? Because you allow analytical experts to actually look at these data rather than keeping them closed in-house where only a small group, often not even qualified, are trying to make sense of the data. Who's benefiting? Us. It's been clearly shown that the consumer in the end, the patient, is the one who benefits from this. It increases productivity, it increases new services. There is a drawback, and I want to make absolutely sure that you understand. The loss of confidentiality is a real threat. When you use the open data concept, emphasis is given on de-identification. It's as simple things like when you go to a medical convention, to a scientific symposium, I still see today that there are catheters shown which have a full ID on top with the name. That's in a way magnified what can happen in open data. There is a role for the government in here, and I think it's very important because the US government is actually exerting a great oversight in making sure that open data sets are not revealing any personal information. And the liquidity of data is one of the big benefits, because for the first time we can actually freely interchange between industries and discover common patterns that actually medicine will even benefit. So we have this unbelievable conundrum that, or a challenge, or actually I call it possibility, where the patient wants to be treated everywhere. There is knowledge that's growing at an unbelievable pace, yet delivery is still a problem. So very simple, if you say the patient's here, you actually want the patient to get help everywhere. And I thought that Dr. Edison had a very good point. One of the things the Indonesian government from the get-go said, we're not going to cover healthcare abroad. Well, there's a good point for that, because Indonesia is the country, something which I had to learn, where the most healthcare dollars per capita are leaving the country. It's the country where the most healthcare dollars go outside of Indonesia. It's a phenomenon that I actually, to be honest, had to grapple with and couldn't understand initially. So let's take a look on how healthcare actually evolved. The first step was the house call. Then came the hospital. Then the hospital specialized. Then the hospital actually provided individual medicine. We're talking about proteomics, genomics, all these things that are on the horizon. However, I propose, and Mayo firmly believes that is, online is wherever you are. So what you can create through the efforts of telemedicine is an immediate access to world-class specialists worldwide who actually can share records through the open data concept with the initial healthcare provider at low cost. How does it work? You actually access the system through your local healthcare provider. I put ECA down because that's where I'm currently consulting, and they can in turn, or anybody, can in turn continue to require expertise. The good part about telemedicine is that it's not one fixed structure. The technology allows you to actually tailor this to how you need it. So one of the things is very common in America, a tertiary care center that interacts with the regional hospital, with primary care facilities, and outreach clinics. First thing that happens is the specialists do not have to leave. They can actually interact through telemedicine with outreach sites. Another possibility is the network model, in which, for example, an academic center, a teaching hospital, a subspecialty facility, a clinical research facility, or a government hospital interact in many ways. For example, a government hospital might interact with an external tertiary care facility through telemedicine. A clinical research facility might work in a trial participation with other centers. Academic centers and teaching hospitals can share training programs, and teaching hospitals and subspecialty facilities can actually participate in active knowledge exchange. What has happened in America, and I believe also here, is something historical. And it's not good, it's not bad, it just was a natural evolution. Well, let me go back and say, the system you put in place can only generate certain results. It's good if you are aware of that. What happened in America? We started out at the bottom and got better and better. We have more and more experts in the field. What did they build? They built, if you call it positive, ivory towers. If you call it negative, silos. What's the problem? The problem is that the expert in cardiology does not talk to the expert in rheumatology, does not talk to the expert in orthopedics, does not talk to the expert in surgery. They do, but they do it mostly by going back down and then over. This is not just a problem with medical silos, as I've just depicted. This appears even in every level of the medical system, where a very well-defined system, like even the patient transport system, is not perfectly integrated into the flow of how a procedure is done. So one of the things we are absolutely allergic at Mayo is the formation of the medical silo. What you really want is the disease-oriented integrated medicine. Take cardiomyopathy. Historically, cardiomyopathy was the domain of the cardiologist. What did an old cardiology department do? Once they discovered that actually cardiomyopathy was often an immune-mediated disease, they would hire their own immunologist to work in cardiology to treat cardiomyopathy. As a result, he may have had experience with cardiac immunology, but the whole vast field, the explosion that happened in immunology, would probably be lost. The same thing is in cardiomyopathy, the infectious disease axis. That's often overlooked. Or then the new surgical options in cardiomyopathy. If you take a disease and say, I am going to staff it with the experts for the disease, that's when you get disease-oriented programs. Why are they good? Because it allows you that the person from the Department of Immunology is in the cardiomyopathy work group. It doesn't mean that you have to hire them to be fixed in cardiology, because once cardiology evolves into something else, these parts are interchangeable and need to be interchanged. That's the part where disease orientation plays a role. This is a picture in Rochester. This is the connection between the Gonda building and one of our hospitals. And I'm just using it symbolically because in Minnesota, because we have cold winters, you see skywalks everywhere. We are connecting everything through skywalks at all levels. What's the advantage of this integration? You have many specialties accessed without delay. The knowledge transfer is markedly expedited. The expertise in different fields is maintained without duplication of this expertise in adjacent fields like happened in the past. And the care is, in this particular approach, the patient is the focus of diagnostic and therapeutic procedures. Why is this so important? And I'm going to switch gear and get into my last topic. It is because in medicine, we are the slowest discipline to embrace change. I don't know if you knew this, but how long do you think it took that the recognition that beta blockers, again I'm using an example from my field, that beta blockers are beneficial in heart attacks? How long do you think it took that 90% of all the hospitals in America actually used beta blockers in heart attacks? Any guess? Years, exactly 22 years. Do you know how long it took Toyota to recognize that their transmission in the original version of the Avalon, and I think it's the same car here, it's a high-end car, how long it took them to recognize that the gear ratio was not optimal in the car after they thought they had it right? Do you know how long it took them to correct that? 2.5 months. So, what's the lesson? Number one, many points, and I'm not disputing some of them. The physicians are a rather stupid bunch, and since I'm one, I can say that. I kind of doubt that because I'm pretty proud that we're pretty smart. We are working in a system that does not allow us to actually translate from recognition into practice really fast. I think there is a lot of truth to that. And we are actually often not understanding what happens in other fields and are interchanging. So what we have actually begun is to understand that the way we go from discovery to actually implementation, that is a science in itself. And that's what we're going to talk about a little bit now. So one of the things that we have found is that getting best practices implemented is the hardest when you have multi-specialty groups that are not integrated. And to make things even worse, it's getting even worse when these groups are not affiliated with hospitals. And I'm going to, since I'm often known that I drag an elephant into the room, is when you have specialists who are practicing at 3 or more hospitals and do not feel, because they are so busy practicing, they don't have time to learn the best practices that that hospital is desperately trying to institute. It can't happen. They are so busy. That's the one thing they don't have time for. So diffusion of best practices is really a concept that I think is critical for making any healthcare system in the world better. It happens in 4 phases. The first phase is discovery. You gotta have curious minds who are seeing things to make them better. The next is the alignment, and is something that is most often overlooked. Is my discovery aligned with how this hospital works? Does the hospital have the resources? Does it have the technology to really implement this discovery? The other thing is, how quickly can I get this discovery into practice? It's called translation. Translation is doubly complicated when you're not dealing with just one, but you're dealing with several hospitals. Now think about the government that has a really good regulation, a good idea for practice, with just 10,000 primary care facilities. How are you going to get all of them to implement the best practice? That's a science. And last but not least, the most important phase, which often is not done, is to continue to measure outcomes, not just outcomes of the practice, but also the procedure itself. And Dr. Edison mentioned this already. What is favorable if you have large institutions, mature institutions that are functionally differentiated, and specialized institutions with professional knowledge? I think it is good to look at the definition. Diffusion of knowledge or transfer of knowledge is the process by which innovations, ideas, knowledge, processes are communicated among the members of a social system, and healthcare is one, such as healthcare organizations. This is really encompassing the entire definition of the dilemma we're talking about. Now, if you look at Overtveit in his really good paper on essential issues for healthcare leaders, it was evident that natural adoption happens, natural diffusion happens with natural adoption without efforts to push them into practice. That has led to beta blockers taking 20 years to actually be in practice. So we actually believe at Mayo that managed diffusion has to be a managed process to get them into all the practices, but in a way that is not impeding the work process. What are the key elements? You need proper leadership. The leadership needs to be completely behind the new initiative. Top management has to be involved. Go do is not something that works in hospitals very well. Physicians do not react very well to that at all. You need to harness the opinions leader influence. You need to development, and this is the part where many of these break down, a formal dissemination process. And while you are doing this, you need to create the appropriate support system. Now, there are 3 critical things you need to consider that are the enablers for this process. You have to look at the culture of the organization. You have to look at the engineering. How am I going to do this? And you got to look at the existing and desired infrastructure to support these initiatives. So when we look at the culture, the first thing you have to bring across that standardized practice are the most patient-centered practice possible. That is actually not to mean that we are all doing exactly the same thing for exactly when the diagnosis heart attack is there. But what you do need to do is you need to document if you deviate from that. Because there may be a good reason why you don't give beta blockers. But you have to document that you thought about it and that there was a reason why you chose not to. For example, patient's heart rate was too low or blood pressure was too low. It's acceptable. But if you do not have standardized practice, you cannot measure outcomes. It's impossible. And outcomes is what will drive the healthcare system in the future. Again, I'm going to drag the elephant into the room. Many Indonesian people vote with their feet because rightly or wrongly they feel that the outcomes in Indonesia are not to their satisfaction. That's the analysis of my answer to why are so many healthcare dollars leaving Indonesia. I'm not saying it's right. It may be a perceived reality, but it's happening. The standard work is the steady state foundation for improvement and innovation. You have to have a baseline from which you start. What is critical is that you create an environment that's psychologically safe, where you can actually encourage the staff that bring forward innovation. The enterprise network has to, especially when you have many sites, has to pay careful attention that information is freely exchanged so that certain stakeholders are not feel left out. The boundaryless approach is something that is actually created a concept by Jack Welch, who was the legendary chief of GE. And what he said is, whenever I think, I look outside my own discipline, because surprisingly many innovations will not come out of the field that I'm staring at, but I look at other fields. Medicine would do well in establishing these processes to actually look at the airline industry, because there is a lot of similarity. The patient either survives or he dies. You either land the plane safely or it crashes. So what does the airline industry do to land planes safely? As a matter of fact, Mayo stole a lot, and I'm saying this with kind of a smile. We adopted a lot of airline processes at Mayo because we found they're very good in having checks to make sure that absolute patient safety and quality is achieved. Because you either land or you crash. That's the same in medicine. By the way, the same approach holds true in the nuclear industry. And it now is apparent that the Japanese power plant that went down actually did not abide by best practices. And they would have benefited if they would have had a checklist like in the airline industry. Now, here are a couple of models that I'm not going to spend some time that you can use to diffuse practices. One is the internal collaboration, where independent teams at each site work with each other. It's inexpensive, but it's very slow. Noah's Ark model is essentially that you put enterprise teams together for discovery and diffuse these best practices. The good thing is that builds trust across the entire enterprise. So this is something that governments can actually use quite often, and the broad input is very helpful. However, there is a tendency to be cumbersome, and it's kind of an expensive and slow process. The alpha-beta model is very simple, is you take a single team and then you say everybody follow the leader, and it's efficient, expedient, but a top-down approach sometimes lacks acceptance. External practices, there's nothing wrong with that. Scandinavia is very good in perinatal mortality, so let's just get their entire package over to us. This is expedient. It usually is based on a broad base of research, but it often gets you into trouble that local customs and traditions are different, and the transposition of the system is not that easy. Grassroots is somebody in your institution says, hey, if we would do it this way, I think we would be better. That's actually when the entire staff participates. It's great because it builds relationships across the spectrum of the healthcare providers, but it's rather slow, and there's often then not a single standard because everybody sometimes discovers the same thing at the same time at different sites. Let me spend just a moment on systems engineering support. You have to have staffing, the facility, and workflow analysis, something that is critical to actually achieve best practices quickly. You have to have human factors and usability study. Is it really fitting in our organization? You got to create the tech support. You have to put into place outcomes and impact evaluation. And impact is honestly across all spectra. Patient satisfaction, quality, cost, because you have to have a viable solution. You got to understand what's the workload I need for that. So we have at Mayo a toolkit, flowcharts, checklists, control charts. And I'm just going to show you how one of those flowcharts look and how complicated these really are. But these are necessary. I threatened Dr. Muska, who organized the meeting, that I would spend 40 minutes on about every box. No, I'm not going to do this. And I actually made it so that you cannot read it, but I'll be happy to give you a copy. Because these flowcharts are followed through with every project that we have. Checklists along the way. Are we on target? Are these lists, are we really there where we need to be? Status trackers. You can see here the various symbols for the various projects. In which level of completion are they? Are they in the planning, realization, or implementation phase? And we put in checks to actually make sure we're staying on target. Timelines to us are very important because when you lose out on it, you lose money. Again, what's the key to success? Is the leadership. You have to have a value creation team that so you have to have a stakeholder that is responsible for each project. You have to have the diffusion action. You have to have the plan for the operational implementation. And then you need to review and maintain these best practices, both from an aspect of process compliant and outcomes metrics. So in summary, integrated care is always patient-centered. It always leads to a higher quality level of care. It combines expertise not just among physicians, but across the entire spectrum of the patient's health care. And it is more efficient, and in the end, it's actually more cost-effective. So in the area of managed healthcare, the healthcare will be increasingly transparent with pressure from several venues to provide outcomes data across a wide range of procedures and disease entities. This will result in benchmarking and the establishment of guidelines to provide standard of medicine, or what we just talked about, best practices. And incorporation of technology is a must to accommodate the ever-accelerating changes. Thank you very much for listening and for having me. I really appreciate that.